All right. Welcome, everyone. My name is Matt Old, and on behalf of the American Head Neck Society and the American Head Neck Society Reconstruction section, Dr. Larissa Sweeney and I would like to welcome you to our third installment of Recon Round the World, joining our colleagues from all over the world. And this time, we're really excited to partner with our colleagues from Korea. And I'd like to introduce Dr. Alice Lin, who will be the moderator, and introduce everyone. I'd like to remind everyone to please use the Q&A to ask questions and not necessarily the chat. So thank you, everyone. Enjoy this. It will be recorded, and the link will go live, and you can forward it to colleagues in the future. So thank you, everyone, and enjoy this webinar.
Thank you, Dr. Old, and thank you, Dr. Sweeney. This is Recon Around the World Korea, specialized techniques for bony and soft tissue reconstruction of the face. And we're sponsored by the AHNS Reconstructive Surgery section. I'm Alice Lin. I'm a head and neck oncology and reconstructive surgeon from Kaiser Los Angeles, and it's my pleasure and honor to moderate today's panel. I'd like to start with introducing the panel. We're very lucky to have three distinguished guest speakers from Korea. We also have Dr. Brittany Barber. She's an associate professor of otolaryngology from the University of Washington. And Dr. Barber is a leader in the reconstructive arena in the United States. For our three guest speakers from Korea, we have Dr. Man-Ki Chung from Samson Medical Center. Dr. Chung is the current president of the Korean Head and Neck Reconstruction Study Group in Korea. Next, we have Dr. Eun-jae Chung, or EJ, from Seoul National University Hospital, and he serves as the director of the Scientific Committee of the Korean Head and Neck Reconstructive Study Group. And finally, we have Dr. Woo Jin Jung from Seoul National University Hospital, Bundang, and Dr. Jung serves as the General Secretary of the Korean Head and Neck Reconstruction. I'm honored to moderate this panel of speakers. Due to differences in density of disease, cultural expectations, and patient expectations, I expect we'll be learning a lot about unique techniques that have been developed in this country that is known for emphasizing aesthetics. So without further ado, I'd like to invite Dr. Man-Ki to his presentation.
Hi, everyone. My name is Man-Ki Jung from Samsung Medical Center, Korea. I'm really honored to participate in this web AHNS reconstruction section. Today, I'd like to share my experience with anterolateral thigh flap for the reconstruction of nasopharyngeal defects, especially in severe radionecrosis. So nasopharyngeal cancer is one of the most common malignancies, especially in East and Southeast Asia. And radiation therapy is either with or without chemotherapy is the mainstay of treatment. But after RT, there are rare but serious complications like post-radiation nasopharyngeal necrosis. So you can use severe pain, foul odor, cranial palsy, and even massive bleeding from the internal carotid artery rupture. So it can seriously impact the patient QOL and even survival. So early diagnosis and the proper management of this problem is crucial. And among many treatment modalities, endoscopic debridement is widely used to remove the necrotic tissues for infection control and symptom improvement. And after endoscopic debridement, resurfacing the surgical bed with the vascularized tissue is often necessary, so it could expedite the healing process and can protect the vital structures like a skull base and ICA. So as for the reconstruction option, nasal septal flap is first choice of reconstruction modality. So it has a robust blood supply and easily accessible, and is proper for small to moderate sized defects. And as for the pre-flap options, radial forearm and anterolateral thigh can be used. And in my opinion, radial forearm, although it has a thin and pliable fasciocutaneous flap, it lacks bulk and soft tissue component, and sometimes it makes it difficult in adapting to previously irradiated bed. So anterotular thigh has more abundant muscle component, so it can aid in dead space obliteration and wound healing process. So, and it also has a very long and reliable pedicle, so it could provide many options for donor vessel selection as well. So I think there are several key points in the ALT flap for nasopharyngeal reconstruction. First, as for the flap design, we could obtain muscle only or muscle with skin. And I think skin is necessary only when you need to make a more airtight closure, like when you have excessive leakage during the operation. So in most of cases, muscle only flap or muscle with fascia flap is enough in this case. And as for the length of pedicle, the longer the better, I think. So in most of the time, facial vessels in the neck is suitable for donor vessel. But when it's not available, we need to use the more lateralized vessel, like a superficial temporal vessel in parietal area. But when you do that, we need to do more, work during the surgery, like secure the path of the vessel by removing the posterior walls or anterior walls of the maxilla. And inset and fixation, sometimes we need to do some anchorage sutures between the bed and the flap. And we can use some catheter to, tag between the flap and the nasal septum to prevent the detachment of the flap and sagging of the flap afterwards. And it's critical to obliterate the entire bed and compress the flap to help the healing process. And during the perioperative stage, it's good to maintain a secure airway. So tracheotomy is mostly necessary, and temporary nasal airway can be used. So I will show a short video clip. It's not the radiation necrosis case, but it's the removal of a recurrent nasopharyngeal chordoma by my colleague, a rhinologist, and flap reconstruction was performed by also my colleague, head and neck surgeon, Nayan Chue. So a 56-year-old male with recurrent chordoma case. So tumor was removed by a rhinologist endoscopically, and the flap was harvested. In this case, this patient has excessive leakage during the surgery, so we have some muscle with the skin flap. And for wider wound exposure, the soft palate was bisected and retracted laterally. And then, as I mentioned, anchoring suture between the operation bed and flap was performed. So it's not easy process due to the narrow exposure. Anyway, 2 or 3 sutures might be enough. And then the contralateral side, anchoring suture is performed with the muscle and the fascia also. And pull up the flap all the way up to the clivus area to cover the defects. And this is the view from the oral cavity. And this is the view from the nasal side with endoscope. The muscle and fascia is covering the nasopharyngeal defects. And for the external compression, he used the suction drain, wrapping the Levin tube with the packing material and introduce them through the mouth and pull up to the nose to make a secure compression for several days after the operation. And the pedicle was pulled out to the neck through the tunnel in the lateral oropharynx. And this is the view after 5 days after surgery. So there's a good healing process after the operation. So in this manner, we have several experience of nasopharyngeal reconstruction with ALT flap. And I have 2 cases. So the first one is 65-year-old male, advanced nasopharyngeal cancer. And after CCRT, local failure occurred at 2 years. And as a salvage treatment, endoscopic resection with the nasal septal flap was performed at that time. But the patient complained of severe and aggravating pain even after the surgery. And imaging study showed progressive necrosis with possible infection. So this time the debridement was performed. And then several years after initial treatment, local recur also happened again. And this time, REART was performed as a service treatment. So these multiple service treatments complicated these conditions and worsened the necrosis and symptoms, as we all expected. But there was no sign of cancer this time. So my colleague rhinologist performed endoscopic debridement and used the contralateral and nasal septal flap again. So as I mentioned, it's a very robust and reliable flap to cover the nasopharyngeal defects. So surgery was performed smoothly and also make some compression with nasal patching. But unfortunately, nasal necrosis progressed and also the flap failed. So he has even showed the C1, C2 vertebrae osteomyelitis and more worsening symptoms. So at this time, we try to use more highly vascularized and sufficient soft tissue flap like anterolateral thigh this time. So he has some impending rupture sign of his right ICA. So preoperative embolization was performed, and endoscopic wide debridement was performed. And ALT flap was introduced through the nose, and she used a segmental catheter. So in addition to several anchoring sutures between the bed and the flap, she also used catheter as a anchoring material, like anchoring the flap to the catheter and pull up the catheter to the all the way up and tagging the catheter tip, the opposite side of tip to the data septum to prevent the sagging of the flap and maintain the catheter for several weeks. And in this patient, the tracheotomy was performed preoperatively, and the nasal compression was maintained for several days after operation. And this is the view from the oral cavity. Yeah. So after several days after packing removal, postoperative progress was favorable, and 1 month, and even after 1 month, flap showed good adaptation. And 3 months later, patient only complained mild neck pain and well ambulatory status, and endoscopic and imaging showed a very well adapted flap and no further progression of necrosis. And second case also has a similar histories, advanced nasopharyngeal cancer, CCLT performed, also local recurrence happened, and REART as a service treatment this time. So he also complained of foul odor and severe headache. So endoscopy debridement, but first option was also the nasal septal flap this time, but the flap failed with the progression of nasopharyngeal necrosis. These two happens always the same time. And this time the ICA was in danger. So STA and MCA bypass surgery was performed by a neurosurgeon 1 month ago, 1 month before the surgery, and endoscopic debridement and anti-flap resurfacing surgery was performed. So the flap was in very good healing process, and 2 months, as you see, the catheter still remained. And after 8 months after surgery, the flap remained healthy, and most of the symptoms were relieved. So this paper published in 2022 summarized the outcomes of endoscopic debridement of nasopharyngeal necrosis with vascularized flap surgery. So most of the patients, first option of reconstruction was nasal septal. 27 patients showed recurrent symptoms and persistent necrosis with or without the flap at the first surgery. So as a salvage treatment with endoscopic debridement, ALT flap was used in 4 out of 10 patients. And after salvage surgery, no patient complained of foul odor and headache symptoms, and the healing process was very favorable in all these patients. So as for the summary, post-radiation nasopharyngeal necrosis, rare but serious complication. So endoscopic debridement with or without flap is a treatment choice. And when you consider the resurfacing surgery with the vascularized flap, nasoseptal flap is the reliable modality of choice in most of the case, especially in initial stage. But in my opinion, in very selected indications, anterolateral thigh flap can play a crucial role for these serious complication management and maybe extensive necrosis involving the body structures like the skull base and the ICA. You can consider the ALT flap reconstruction as even the first option in this case. And as a service procedure, ALT can play a crucial role. So especially when initial nasoseptal flap failed with persistent nasopharyngeal necrosis. In this case, when you use the contralateral nasoseptal flap, it's a highly chance to fail again. So you can consider the ALT flap. And in some cases where there's a CSF leakage, you need to obliterate the space to prevent further leakage. In this case, you can use the more free flap with abundant soft tissues like anterolateral thigh. Yeah, that's the end of my talk. Thank you.
I think you're muted, Alice.
Sorry about that. Yeah, that's wonderful. Thank you so much. This is a significant experience in a very difficult disease. I think it's a problem that many of us reconstructive surgeons are reticent to tackle because it's even more rare in the US and also very challenging location to reconstruct. But I know that the pain and the headaches are really debilitating for nasopharyngeal ORN. Dr. Barber, do you have any comments about reconstruction for this disease?
Yeah, thank you. Thanks, Allison, Mankey. These are really challenging situations because these patients are often young, often really heavily pre-treated. And usually by the time a free flap surgeon is involved, they've already had multiple surgeries. And sometimes that's within a fairly short time frame. So in fact, I think all of those were the case for the last case I did about a month ago. We do, while it's not nearly the experience you guys would have in Korea, we certainly see this a lot in Seattle just because of geographically where we are.
Mm-hmm.
And I think the trouble is sometimes the disease is in a stage of evolution when you're seeing it. And so you know that it may not be the last time that you're there with a free flap. Hopefully you are, but sometimes you have to plan for more reconstruction later. So I certainly agree with you, Mankey, that an ALT is better than a forearm. I certainly know that there's lots of folks out there that prefer the pedicle. Just because it's much more reliable. ALTs, you have to worry about perforators. You're worried about the length of your perforator flap of your pedicle if you're going to have to do a vein graft. And in fact, the last time I did do this, the vessels had been reirradiated in the neck, and I actually had to anastomose in the mouth because the neck vessels were not even appropriate or reasonable for a vein graft. So I would say that that is an option. Wasn't my favorite option. It worked fine, but that was a difficult situation to be in. And so I would maybe heavily consider for those folks that are out there, when these central defects occur or central osteonecrosis occurs at the skull base, seriously consider anastomosing on the contralateral side if it is reasonable. A question I had for you, Mankey, is just about where you like to bring your pedicle out for these. That's kind of an area of debate that we have here. And some folks, I prefer to do a maxillotomy and just bring it out the maxilla and down into the buccal space. Other folks prefer a more posterior approach. And I see that you mentioned superficial temporal vessels. And what's your preferred location for your pedicle for these?
Yeah, mostly the facial vessel if it's available. So make a tunnel through the lateral oropharynx is more feasible and accessible. So I personally I don't have experience using the parietal area, buccal area, but I heard there's my colleague in other institution who use the superficial temporal vessel and by removing the walls around the maxilla or pterygoid plates and they introduce the vessel through the Caldwell look port in the cheek. But after the surgery, they said there's some after the healing process there's some tension between the around the vessel area. So the healing process was not favorable at that time. So I think it's available. Using the neck vessel is more good in this case. Yeah.
Well, certainly would have preferred to in that last case, that's for sure. But yeah, I just maybe would ask the other folks on the panel if they have any experience, if they have a preferred pedicle location. Like I said, I would prefer to go. I usually just go through a maxillotomy and then through the buccal space. But I wonder if you have any thoughts on that, or Alice, if you do.
No, I just wanted to also add the question that I had the same question in my mind, but do you guys have any tips for avoiding a salivary leak from the pharyngotomy? Or do you choose muscle only or muscle and skin for those reasons? And also, do you have any tips for passing the pedicle or passing the flap through the tunnel to prevent shearing of the perforators?
Ujin or EJ, do you have any ideas on that?
Oh yeah. Well, actually, I was going to mention that I do have a case that I will be showing using the superficial temporal artery, but personally, I feel that the superficial temporal artery is a little bit less reliable compared to the neck and the facial artery. So if I had the option, I would definitely go for the facial artery, and I would try to dissect as much as I can into the buccal space. And then sometimes you can actually do the anastomosis in the neck and then bring it up and then, take it to the area. But that's for actually maxillectomies. Maybe not, it may not be applicable to nasopharynx because if you've already done the anchoring sutures and everything, it'll be difficult for you to bring the pedicle down to the neck.
I guess that is another point here, is that sometimes I've certainly done these where there's already been an element of maxillary ORN as well, and that makes things a little bit easier because you can really just bring the pedicle and the tip of the flap out the posterior to the molars. A little bit more difficult when you're not able, when you're worried about, or when you don't have that defect and you're having, at least for me, to bring it through the maxilla. I was going to ask Manki as well, just do you find that the skin provides a good seal? I always I've had difficulty placing good sutures.
Right, yeah. So the video clip I showed is my colleague. So he used the skin to make some airtight closure. There was CSF leakage during the surgery. But I'm totally agree with you. To make a skin to mucosa suture in this area is quite difficult, and sometimes there's a delayed, detachment of the flap because of bulkiness and the healing process. So even if there's a CSF leakage during the surgery, I prefer to use muscle with the fascia only flap and make a good compression. Might be enough to prevent the further leakage. Yeah, skin to mucosa suture in nasopharynx is not easy.
Yeah.
Yeah.
Well,
And
this is, go ahead. Sorry.
Oh, I was just going to ask what your preferred length of time for nasal packing is. I think we tend to be conservative here, and the patients are usually driven a little crazy by the amount of time we have them packed. I'm not sure if you have a time frame in mind.
Maybe less than a week. Yeah.
Oh.
5 or 6 days after the surgery. Yeah. But the patient has to maintain the pharyngeal feeding by like a labyrinth tube on the nose and the tracheotomy. So healing process is not easy for the patient's perspective anyway. Yeah.
Well, thank you. That was a wonderful presentation. In the interest of time, we'll go on to our next presentation by Dr. E.J. Chung.
Okay, thanks, Alice. Good evening and good morning. This is Eunjae Jung, EJ from Seoul National University Hospital in Seoul, Korea. Can you see my slide?
Yep.
Okay. Yeah. First of all, thanks for the organizing committee for the wonderful webinar. I'd like to talk about the triple reinnervation of facial nerve during radical paroidectomy. Sometimes we have to cut the facial nerve even if it's functioning. The classic option for reinnervation is to use a single long interpositional nerve graft Unfortunately, it doesn't work in many cases. So this is the approach I use for reinnervation. Eye closure is covered by facial nerve in the temporal bone using the interpositional nerve graft. Smile is covered by the mesenteric nerve in mesenteric muscle, and the marginal mandibular nerve is reinnervated using AHNS subcalis. This triple reinnervation technique can make more symmetric and strong muscle contraction and less synkinesis. I learned this technique during my fellowship in London, Ontario. Let me show you a video clip. The first step is to find the facial nerve at the distal part for retrograde facial nerve dissection. The zygomatic branch is located at a point that the line connecting incisura and the lateral canthus meet the zygomatic arch. And the buccal branch is found along the line connecting the incisura and the philtrum. And so find the facial nerve and keep going on a retrograde dissection from the point to approach the area close to the tumor. And try to get a healthy and thick segment of facial nerve whenever possible. The marginal mandibular nerve is at the marginal notch, mandibular notch. Then cut the secured temporal zygomatic buccal marginal mandibular nerve branch of facial nerve at a safe point and confirm the absence of tumor with frozen biopsy. Then we proceed with the radical compartment resection from the distal area away from the tumor. During neck dissection, we also secure the ansa subcalis. You can see the ansa subcalis. The facial nerve root is sacrificed without identification. For a wide parapharyngeal space exposure, the digastric muscle is cut. And the external carotid artery is ligated. And here we can see a radical compartment resection. After the ablation, next step is to find the mesenteric nerve. The mesenteric nerve can be navigated in the mesenteric muscle at a 0.3 centimeter anterior to tragus and 1 centimeter inferior to the zygomatic arch. Then drill the temporal bone to find a healthy facial nerve root. We don't use any additional post-auricular incision. We drilled out the mastoid and find the facial nerve root. This is the facial nerve. And after we get it, then they check the frozen section. And then adipofacial free flap is harvested from the radial forearm, and it will be used to cover a long segment of avascular interposition nerve graft in the face. I want to use it the vascularize the free flap tissue for better and enough regeneration during the postoperative radiation period. So we could get a long and healthy nerve, and also we could get a palmaris longus tendon in the forearm easily in the same field. And this is the coaptation stage. This is the mesenteric nerve in the masseter muscle. The coaptation between the mesenteric nerve and the distal facial nerve branch that innervate the zygomaticus major muscle for smile selectively. So mesenteric nerve. And I only use for the facial nerve branch for the smile. So I choose it selectively. And coaptated with the mesenteric nerve. Mesenteric nerve is not a big thing, but not big nerve, but we can always find it using a nerve stimulator with navigating the nerve. For the nerve to the orbicularis oculi muscle for eye closure, the interpositional nerve graft from the forearm is used to connect the facial nerve root in the temporal bone. And then anosmos coaptation between the ends of subcalis and the marginal mandibular nerve. And I think this is an optional. So if we skip this step, that will be a dual reinnervation. If we do this step, it will be a triple reinnervation. Let me show what is the routine postoperative course of this patient. This is a 74-year-old gentleman with no preoperative facial palsy, high-grade mucoap, widely around the facial nerve root. So resection, including the facial nerve root and reinnervation. Postoperative 1 month, left side. So no eye closure, incomplete eye closure, and no smile. This is a 3 months. Smile movements start usually about the 3 or 4 months after surgery with clenching teeth. Eye closure continued to improve up to 1 year post-op. This is 1 year after surgery. Mouth excursion also recover naturally. However, in most cases, some level of oral ocular synkinesis is inevitable. This is 2 year. Good eye closure, good smile, synkinesis. The nerve regeneration could be verified by EMG study. 25-year-old gentleman, no preoperative facial palsy, facial nerve root sacrifice inevitable. This is a 2 year. Patient right side, good eye closure, symmetric smile with clenching teeth, right side. We can see the full recruitment in the orbicularis oculi and zygomaticus major muscle at the EMG study at 1 year post-op. This EMG significantly improved until 1 year, almost comparable to the level of normal side. In most cases, smile can be typically by just clenching teeth, not a natural, that is not natural smile, but as this case, natural Duchenne smile sometimes can also develop. 21-year-old lady, recurrent parotid cancer, facial nerve sacrifice. This is the preoperative view of the patient. This is the 8 months after surgery. We can see a good eye closure. And also we can see a natural smile. This is not by a clenching teeth. This is by just a natural smile. I think maybe one of the branch from the temporal branch is innovated, the zygomaticus major. Let me show you my personal experience briefly. In total, I did 34 single-stage facial reanimation surgery with radical parotidectomy. Of this, the re-innovation was 28. In 6 cases, I did an alternative reanimation procedure such as temporal tendon transfer when I could not secure the healthy facial nerve segment. Among the 23 who had a re-innervation and follow-up at least the 6 months, about 74% could get a symmetric and near full or full facial muscle contraction. For eye closure, 78% could achieve the near complete or complete eye closure. For smile, 74% showed at least full incisor or canine on smile. 39% the obvious synkinesis, mostly the oral ocular synkinesis. So we did an analysis using the Emotrix software. So all variables showed a significant improvement at 1 year post-op. And at 1 year, it was comparable to the normal side. This is end of my slide, and thank you so much. Thanks.
EJ, those are beautiful facial nerve reconstruction results. Thank you for sharing that. I love the commitment to facial nerve sacrifice from the beginning. And I think a lot of surgeons are reticent to do that or don't want to do that right away. But I imagine by committing from the beginning, the surgery goes more smoothly, your oncologic margins are better. So I think that was really cool for me to see. This isn't so much about surgical technique, but we all hear that in Korea, aesthetics and scarless surgery is very important to the population. How do the patients take it when you tell them you're going to sacrifice their facial nerve? And what do you tell them in terms of expectations?
Okay, I think that's a really important point. Most of this patient is a normal facial function usually, but it's not actually the invade the facial nerve itself, or even in the pathologically. But we know that it encased the totally 360 degree of the facial nerve, very extensive amount. So if we try to save it, we should violate the tumor. So I always explain the situation to the patient and the characteristics of the parotid cancer. And also I think the most important thing is I always show the post-operative result at 1 year, 2 year of the patient movie. So because the patient always afraid of if my facial nerve gone, how could I live, or what will be my job, what will be my family? So they always worry about it. But so I always told the patient, showing the movie, you can do yourself, you can save your family, you can do your job even for as a lawyer or something. So usually, and then after they see the movie of patient post-op, usually the patient agree if the tumor is suspected a high-grade tumor.
I think we have a couple of audience questions. One is, would you use Enticide with hypoglossal instead of AHNS cervicalis? And also another question, do you always involve a neuro-otologist in these cases?
Yeah, thanks for question. So I always use the AHNS cervicalis. That's the technique that I learned in London, Ontario. But I know some surgeons use an Enticide technique of the hypoglossal nerve, but in my opinion, the reinnervation of marginal mandibular nerve is not a point. That's not so important. I think the key is the eye and smile. So the priority of that is not so big. So I just use an AHNS subcalis. And also the otologist always comes in and they drilled out the temporal bone. At the beginning, we just extend a little post-auricular incision, but we got to know that we don't need it. We can drill out the mastoid and can get a facial nerve segment in the mastoid just with the same incision there.
Dr. Barber, you've done some research on peripheral nerve in the head, and a lot of research on peripheral nerve. Any comments about this case?
Well, I think these results speak for themselves, really fantastic. I guess I did have one question. You certainly get some quite a bit more volitional smile with masseteric nerve transfer. I'm just wondering, do you ever anastomose one of the other buccal nerves to the main trunk with a cable graft to get tone, just resting tone? And is that also your thought with the ANSA, that you may get some tone rather than volitional smile there?
Thanks. So just I think I have one case of the massacring one or two case to the buccal, not a zygomatic. But I think the distance from the massacring nerve to the peripheral facial nerve branch for zygomatic is more close. So I like it, and also I think compared to buccal, zygomatic branch is more important because zygomatic, although the synkinesis problem, but the zygomatic branch controls the eye and smile both, but buccal usually only controls the smile only. So I think that's the advantage of zygomatic branch. So, and also the buccal to the main trunk of facial nerve, I didn't connect it. I have no experience. But I think that's good idea. But my preference is always for connect the main facial nerve to the eye closure, because eye closure, I think in terms of the long follow-up, long time after surgery, I think, I mean, the 5 years, 10 years after surgery, the main issue also is very important thing is the eye protection. So if the eye is not reinnervated properly, the eye will be the ectropion or something. So patient will suffer from many things. So reinnervation to eyes, I think, also very important. So always try to reinnervate the main trunk to the eye usually. Thanks.
I think you're muted, Alice.
Why I keep doing that? Because I have a cough. Sorry about that. Okay, thank you, EJ. I
Thanks.
think we need to move on to our last
Thank you.
presenter, Dr. Ujin Chang.
Can you see my slides well?
Yes.
Okay, thank you for inviting me to participate in this panel. I will be talking about maxillectomy and mid-face defects, but before I go on, I'd like to show a slide. I'd like to tell you that we also have a webinar hosted by our society. So this is one that we did last year. We do it typically 2 or 3 times a year. You can see Professor Chung is also one of the panelists, and I can see Professor Seiichi Yoshimoto in the audience. And yeah, we invited many people from the Asian countries to do this kind of webinar. So if you're interested how we do it in the Asian countries, you can also join from the US. I don't think the time will be very favorable for you, but still you can, yeah, try. And then the second thing is we are undergoing crisis in Korea because of the healthcare system is in danger. The current president actually increased the enrollment of the medical students from 3,000 to 5,000 in just one day. And then we're going to have like 170% of doctors coming out because he thought that Korea has a shortage of doctors. And the medical students went on a leave, the residents went on strike, and actually the president has been impeached this week. And so everything is a mess. And the problem that I have is I haven't been able to do much reconstruction in the last year because I do not have my residents and I do not have colleagues who can, follow up on my cases. So anyways, with that, I like to talk about the maxillectomy and mid-face defects. My previous presenters have vast and more experience than I do, and they have more advanced techniques. But I'd like to go through some of the everyday questions that I have when I do the maxillectomy and mid-face defect and reconstruction. And I would also like to make this a little bit more interactive. So I'll be asking questions to the panels and what ideas you might have about my case. So brief introduction. This is a classification of the mid-face defects that comes from Liverpool. And this is an article by Dr. James Brown. And we are all familiar with this classification. The ones that we see often are the type 2 and the type 3 maxillary defects. Type 4 is a one that goes with the orbital accentuation. Type 3 is one with the orbital floor defect, but the preservation of the orbital contents. Just 10 years after the initial article, Richard Shaw is another guy in Liverpool, and he came up with additional 2 more classifications. However, we still see more of the type 2 and 3 defects, and they have shown in their case series how different free flaps and options we have for this kind of defect. By the way, I will be also attending the IAOO in July, which is going to be in Liverpool, and Richard Shaw is the president for that event. So if anybody of you coming there, it'll be nice to meet you guys there. And available options that we have for the mid-face defects, radial forearm free flap and the ALT are the workhorses. I try not to use the radial forearm free flap because of, as Alice has already mentioned, cosmetic reasons. And usually this is an option for the just the palatal defects, if I have any. ALT, you can use the vastus flagellaris to get a very big bulk. So that's my workhorse flap. Another flap that I want to introduce during my talk is the medial sural artery perforator flap, and it's a very good alternative to the radial forearm because it's very pliable and the defect is cosmetically much better than the radial forearm. And if you're going for the bony reconstruction, of course, fibula is the main option. And although I'm not familiar with the scapular system, I know that in many parts of the world that many people like to use the scapula. So this is a case. It's a Brown 2 type cancer, epithelial myoepithelial carcinoma. I always collaborate with my rhinology colleague, and he did the resection part. So he did a mid-face degloving approach without any facial incisions. It was endoscope assisted. You can see that the premolars and the molars are resected, but it's mainly a type 2 resection. The palate mucosa was preserved and the premaxilla was also preserved. So I want to ask the panel, what are your reconstruction options and what do you consider for your vessel anastomosis? So anybody?
Well, I'll jump in if nobody else will. I was just going to say these great slides here. I would maybe add that in some cases like this one, I would maybe consider an obturator rather than reconstruction too. Some of my happiest patients are obturated patients. So I certainly throw that in the mix here. And so aside from that, you know, something as small as this in that space, bony recon options are going to be a little bit difficult to get in there. So unless the patient is really motivated for dental restoration, which I think is a problem here in the United States in some places, you know, this is something that's not covered by our healthcare system generally, then I usually will do a soft tissue flap in this area, again, unless the patient is really motivated for dental restoration. But welcome the other thoughts of the panelists here.
Yeah, I think obturator will be a good option in this case. Yeah.
Oh, thank you for the input. Oh, yeah, Alice, go ahead.
So one new thing I have been doing for younger patients, I'm seeing that my cancer patients are getting younger and younger. And I think the obturator is a great option. But you know, in the younger patients, some people call the obturator the what is it called? The delayed dental extractor, because over time it does kind of put a lot of pressure on the dentition. So one thing I have started doing recently is something called IPS pre-prosthetic. It's made by one of the hardware companies it was developed in Germany. I don't believe it's available in Asia. It just got FDA approval in 2023. So that's one new option that I've been doing more mostly for younger patients, where, you know, I'm trying to, and I don't know what the long term of this is, but in my mind, if this failed, they have other reconstructive options in the future.
Oh, yeah. I mean, it'll be wonderful to have that option in Korea also, but I don't think I have that option. So this was done a couple of years ago. I used the superficial temporal artery, which we already discussed a little bit about. I used the ALT, and in Korea, actually, the ALTs are relatively thinner than those that you encounter in the US and other parts of the world, as I have heard. And actually, it did a good job. And as you already mentioned, he doesn't have dentition on his left side, but he's okay with it. His facial contour is fine, so he's living well in this condition. This is another case. It's a peculiar case. It's a Brown type 2. If you have to categorize it, it was done by my rhinologist, oncologist. And he went in for an excisional biopsy, and then he found out that it's a adenoid cystic carcinoma, which was infiltrating into the incisive foramen. So he resected the incisors. So you can see that he made the mid-face degloving incision. It's the same surgeon, so he prefers to do it this way. And then he removed all 4 incisors in the front side. I'm just showing this case because I want to introduce you to the MSAPF, which is the medial sural artery perforator flap. It's a very good alternative to the radial forearm free flap. Otherwise, I would have gone for the radial forearm, but this one offers very pliable flap, and also you can get a considerable amount of area of the flap. The downside is actually that the pedicle is a little bit shorter than the radial, a lot shorter than the radial forearm. So I tend to use it for defects of the oral cavity rather than for maxillectomy defects, but I just wanted to show you that there is another option for the radial forearm. I like it very much, so I actually wrote a textbook chapter on this. It is in Korean, but the figures are coming from that chapter, and you can see this is in the medial side of the calf, and it's very thin. For this case, it's about 4 millimeters thick. I can get tip flaps as thin as 2 millimeters or even less. The perforator is very readily and easily seen, and you can see it fits nicely into the oral cavity, and the donor side defect is very easily hidden when you're wearing trousers. So the second part, actually, this is the one that I have the most questions to the panelists, because when you do a Brown type 3, you have to consider a lot more ophthalmologic considerations. So for Brown type 4, which I'm not going to be going through today, you just need a huge bulk to fill up that space. But for type 3, you have to take into consideration the eye. So this is a report coming from a group, the plastic surgery group in Korea, and they compared tensor fascia lata sling, which is autologous, compared to a absorbable sheet or titanium mesh. And they have shown that the wound complication is much more in the foreign body, the absorbable sheet and the titanium mesh group, and more plate exposure and more ectropion in this group. And the autologous group has a much favorable outcome. I think because of the reporting purposes, this is a little bit more exaggerated. But I want to ask the panelists what your preferences are for the reconstruction of the, for the support of the orbital contents after a Brown 3 resection.
I have to admit, I'll just start. I'll have to admit that I don't really I don't understand the eye very well. So sometimes it's nice to just order something from a company and they're like, this is what you put in, and that's great, because then I don't need to like worry about it. And if it doesn't work out, I send it to the ophthalmologist. But I normally would do a fibula free flap to support the orbital floor. Dr. Barber?
Yeah, I tend to really like a scapula tip for this, especially with an orbital floor involved. My fellows would tell you I really hate putting mesh in if I can avoid it. So I certainly respect the paper that you're talking about here. I've gone to doing ipsilateral scapula and flipping it vertically and horizontally, and then cantilevering the tip down to provide support for the orbital floor. The tough thing is that if you don't have a big defect, then it's a lot of bone to fit into a small space. On the other hand, if you don't have enough frontal bone to plate to, that can be problematic as well. But I do take a lot of time and effort to, if I'm going to use any mesh or any hardware, to cover it with latissimus, with alloderm on top of that mesh as well, to separate the orbital contents from the mesh so that they don't get integrated with it. And I'm very particular about stuffing a decent amount of muscle between the mesh and the orbital contents, because if that extrudes, it's very difficult to fix and almost always requires another flap. So, that's what I've been doing, but it is a bit fiddly because it's a lot of bone and a lot of soft tissue to fit into a small space. But I welcome the comments of the other panelists here.
Yeah, I do have some more questions behind, so let me just go ahead. Yeah, you guys are probably all familiar with this kind of very detailed and very nice 3D reconstructions. For Brittany, do you use the routine 3D recon like this for the scapula system in your practice?
Yeah, so do you mean, do I use VSP or what?
Yeah, VSP like routinely, because many people apply it for the fibula. I'm not sure like you use it routinely for the scapula system.
Yeah, for the scapula, I find in my hands it's quite a bit easier to contour than a fibula, in particular for the orbital floor. So I don't use it routinely. It depends on the amount of I think the size of the defect. But a lot of people will use cutting guides on the scap tip, and I find that there's a couple of reasons I don't love doing that. One, it never fits perfectly on the scap tip. You have to strip some of the muscle off, which I don't like doing. And the last reason is that you can never really predict exactly where the angular is coming in. So in my hands, I don't necessarily always use it, but completely understand why others do.
Got it. I don't routinely always use the 3D reconstruction because when I started out, actually it was not in the insurance system. And in Korea, if you do something that is not in the insurance system, you could go to jail for that. So you're not allowed to do some things that are not in the insurance system. So, but afterwards, we did develop the insurance policy, and also there were some companies that doing this. So this is a typical 3D reconstruction. If I do a bone flap for the reconstruction, I would segment it into 3 pieces, and I would usually use one for the mid-face support and also for the orbital floor. The other one for the nasal vault. And then lastly, if the patient is undergoing a dental rehabilitation later on, I have another piece coming here. When you do a 3-piece or even more 4 or 5 pieces, it has to have a perfect fit. Otherwise, it's gonna dangle around in the midface. So fortunately for this case, it was all done pretty nicely. You can see the cutting guide here. The orbital contents are preserved, and this is the nasal vault side. It had been done exactly as it had been designed, but because we have a different ablative surgeon, and the reconstruction surgeon comes in, and then he's taken out a chunk which was not prepared to be, and it sometimes is very difficult to cope with when you have already a plan, but it just changes in the middle of the surgery. Anyways, the skin paddle is used for the palatal defect, and actually for him it was very nice. So after even the radiation therapy, his facial contour was very well, remained very well. But it is not always the case. I have to show this kind of case because I do encounter from time to time these complications, and I believe that all of you might have some experience. So we could have a palate and bone exposure, palatal fistula, and you can see the screw through the mouth. And sometimes, many times after radiation therapy, you can get this kind of a defect. And also the ectropion is always a problem in my practice. So any experiences that you want to share, or any solutions, or something that you might want to do with this, any input is welcome. So Alice.
Yeah, I mean, this is a tough problem. I've seen it before, though. And in this situation, I'm not looking for a slam dunk. I'm looking to kind of temporize the situation, give him enough function. So usually in this situation, I would do soft tissue. So I take out the hardware, take out all the bad bone, probably most of it. When you go in there, none of it looks perfect after radiation, and it's been open to the world, and then work with the ophthalmology colleagues on slings and things like that to support the eye. But yes, you're right. I've seen this too.
Yeah, Monkey, I think your mic is on. So do you have any?
Yeah, I'm agree with Alice. Removing all the inviolable, bone and plates away, and restore the space with the soft tissues, and work with the ophthalmologist to recover the more aesthetic touch-ups for the around the eye.
Certainly agree.
EJ, do you have any? Sorry, Brittany, go ahead.
No, I was just going to say, I certainly agree. Unfortunately, these often require a second flap, and then you're putting another pedicle through a already radiated and tough and scarred tunnel. And so they're really difficult cases. So it happens to everyone.
Yeah, okay. EJ, I'll prepare a question for you with the next slide. So that's why sometimes I kind of move away from the bony reconstruction, and then kind of settle with the soft tissue reconstruction. But always there's an issue of the the lag of thalamus and the ectropion. So this is one of the reports from our colleagues in Korea, and they mentioned the use of the vascularized fascia lata, and they anchored it to the posterior nasopharyngeal mucosa, and then to the nasal bone and the zygomatic bone after drilling the bone. So it's a 3-point fixation, and that will be a support for the eyes in case you're using just the soft tissue. And that is exactly what I had done in this case. It's the ALT with vastus lateralis included, and you can see I have the tagging sutures on the periorbita, and the sutures are done after drilling the zygomatic bone and the nasal bone. And the patient is doing pretty well. Is a young man. He had a squamous cell carcinoma of the maxilla. Initially, it looked very bulky, and you can see the bulging in the palatal area. But after 2 years, and also he has undergone the radiation therapy, the bulk has been gone, and the facial contour is rather symmetric on either side. So EJ, my question is, do you prefer to do a bony reconstruction or just a soft tissue reconstruction, or what are your indications if you would use both at a different time?
Okay, so my preference is, so it's changing, I think, but my preference is, my priority is to make an anterior buttress. So I think that's the most important thing, to keep the orbit floor, prevent sunken down. So always try to make an anterior buttress. So my preference is scapulative, but sometimes, the pedicle problem, I mean, the short distance or something. So sometimes I need a vein graft or something. So it's changing. I'm changing. So sometimes just only lip on free lip bone graft and wrap up with a lat muscle, or just a customized plate for the anterior buttress and wrap up with the rat muscle. I think it's very difficult issue,
Brittany, do you always go for the scap tip, or do you also use the soft tissue? In that case, is ALT one of your options or other options?
Yeah, thanks for your question. Yeah, so I think a lot goes into that decision. I think certainly some of these folks where you're doing a relatively big resection are maybe not going to have the best prognosis. You don't want to take any chances. You want to make sure they get to radiation as soon as possible so that there's no chance that they have the best chance at survival. And so in patients where they're a little bit older, they've got multiple comorbidities, they've got pretty bad disease, sometimes that is going to be a better option. I do find that occasionally when you're doing that, gravity and edema will take hold of the patient, and then you end up with a lot of protrusion into the oral cavity, and then they end up with issues swallowing simply because of that, just after all the edema sets in. And so I prefer, if I'm going to do a soft tissue flap, to do something that I can tether. So an ALT is usually what I'll go for, just because it has TFL that you can tether and secure to bony structures in order to make sure it doesn't fall down into the oral cavity after all the swelling takes root.
Yeah. So I also wanted to mention the issue with the flap volume shrinkage. So this is an article out of Korea also. They reported ALT volume reduction after 12 months of about 20%. And the other one is coming from China, and they mentioned even like a 50% volume reduction in the free flaps. And they saw that after a adjuvant RT, actually the volume is shrinking even more. And as you can see in this case, it was very voluminous in the initial period, but then it kind of shrank down after 2 years. So I think that is one consideration that you have to take into when you're doing these kind of flap reconstructions. Another thing Brittany has already mentioned, I do consider obturator for many of my patients also. This one, I like it, especially because I thought this was from the dental department, but actually it comes from the head and neck and the plastic surgery department, saying that when you use the obturator, the unrestricted diet rate and the excellent speech rate is actually not that different between the free flap and the obturator. And they also mentioned that when you use the obturator, you can see they have applied this to a older patients cohort. And to the patients that have have been irradiated previously, and their surgical time is less than 1/2, nearly 1/3 of the free flap operation time. And the average hospital day is also 1/3 of the free flap cohort. So I think this is a really good option for the older patients. And if you have a small defect, and if the patient is not so much interested in having that free flap in your mouth. So some of the small defects and the old age are not suitable for long surgery, and the inability to apply a dental implant. So Brittany, you shared your experience. So anybody else who want to tell us in how many proportion of the patients you might recommend obturators and how they're doing?
Let's allow time for one more comment. And then we do have a question from the audience I'd like to do too.
Okay.
Any more comments about this obturator?
Okay, we can skip this one. Actually, that was my last slide.
Okay.
So yeah, I would just want to wrap up by saying that for Brown class 3, soft tissue and bone, as EJ already mentioned, I go back and forth, and I'm not exactly sure about the indications myself. But for the we have to consider the orbital support, and then bone tends to come with more late complications, such as bone and plate exposures, and you have to also think about the volume shrinkage. So that's the end of my slide.
So we have one question though. We have a question from Dr. Jamie Koo from Cleveland Clinic. It was probably about when you showed the 3-segment fibula reconstruction. Do you fixate that inferior 3rd segment posteriorly?
No, I do not. I just leave it hanging. Yeah.
That was a wonderful talk. Really great discussions. Thank you to the entire panel, and thank you for sharing also, Woojin, your thoughts, what's been going on in the Korean medical community as well as the political arena. And I think outside of reconstruction, it's really important that we know what's going on around the world. So I really thank all the speakers today, and I had a wonderful time moderating this panel.
Thank
you
you
all.
for having us.
From you.
Thank you.
Appreciate it.
Thank you.